So Kristen suggested that John and I met, and John Cohen, who was, I think, one of, if I understand the story correctly, John was the instigator for this meeting, and John and I did meet at Princeton for lunch, but we actually were at college together, at med school together, where we roomed together, and then we roomed together at Stanford when we were both in residencies there. John went off into psychiatry, I went off into anesthesia and critical care, and then subsequently revisited each other at Princeton, where I was initially doing a leave of absence and then taught there for a bit. And we met with a third individual, Kai Lee, and had this luncheon discussion about wouldn't it be cool if we could do real-time MRI decoding and use that as a way to help with clinical care of patients. This was about 10 or 12 years ago, and John said, well, obstacle number one is we can't do the real-time MRI decoding because we don't have the computing power. Kai Lee, my colleague, was a computer science professor and said, oh, yes, we can. Worked with Intel, and we managed to develop, or they managed to develop machinery to do that. We now have, and I'm going to describe this in sort of in a little bit of a schizophrenic way because I'm not sure how this ended up happening, but I am now the administrator against which John was railing earlier. I'm the CMIO and have to represent the health system's interests in thinking about data privacy and data sharing and the like. So I think I'm going to try to be instructive about the way that an organization like Penn Medicine thinks about data, its responsibilities towards its patients, and use that as a construct. And I'll finish up with some slides that look alarmingly like Kristen's slides in terms of how we've thought about that. But our project basically is along the lines of as follows. We put a patient in an MRI scanner at Penn, fMRI scanner. We present them with some stimuli. Those stimuli then result in an fMRI image, which is uploaded to the cloud, processed in the cloud. Based on the outcome of the processing, the loop is closed with a stimulus back to the patient, a visual stimulus that will be altered based on the results of the scanning. So I don't know if that makes sense, but essentially there's a patient on site on our campus. The data is uploaded to the cloud, processed there, and then there's some computing that's done to close the loop, and you have the ability to do real-time closed loop stimulus and potentially treatment of the patient in the scanner. So in order to accomplish that, I just want to outline some of the obstacles. John presented the obstacle of the legal folks, and that was certainly one of them. But we had issues, as I mentioned, in the larger session with our IS shop, with our IRB, which was not really so much legal. And all of those things had to be navigated in order. It took us a number of months to do that. We have successfully done that, and would be a use case that I think we could refer to at some point down the road. So our patients consent to admission and treatment, and one of the things that we've had to grapple with recently is consent for data sharing. So all of the patients are in the health system on a single EMR. In our case, it's the Epic electronic medical record, and therefore automatically susceptible to data sharing between other Epic organizations using a Epic backbone for data sharing. We also use what are called health information exchanges for patient data sharing with other non-Epic organizations. And this is clinical data, this is identifiable data, and patients, in our case, need to opt out. We've taken the principle that data sharing is in the interest of patient treatment, and therefore, in order not to have your information shared, you have to opt out. Another obstacle we've dealt with is that historically our IS shop has been. IS is information services. Our institution covers both the corporate and the academic side. So we're straddling Penn Medicine in the health system and then the research. The same IS organization serves both. It's historically been a on-site focused IS shop, and it's only recently, and in part due to the research we were doing with Princeton, that we've been able to open the doors to using the cloud as a data storage location and as a computing vehicle, and partly because it took a while for Google, for Amazon, and for Microsoft to sign what are called business associate agreements that Kristen referred to. So to take some responsibility for the data that they're hosting and the loss thereof. Now I think all three of them now have capability to do BAAs, and we've been working with Microsoft and using Azure as our cloud computing environment. Our clinical health system computing environment is very locked down. The health system is under constant attack in any number of ways. We have ransomware. We have people trying to fish for information. We have loss of patient data, either through loss of unencrypted laptops. I mean, there are a number of ways in which a health system is extremely risk averse and under constant threat, because if we have a breach of sufficient magnitude, there's a lot of public shaming, there are financial penalties, and so we have to straddle the risks side of the equation with the fact that we're a research environment as well, and have to facilitate research. So, the researchers in general tend to be more loosey-goosey. They want to have open systems, open data exchange, movement of information from on-premise to off-premise, and that's a major constructive tension that we have to deal with. And I guess the last point I'll make before I go to my governance slides is that genomic data is now something that's clearly re-identifiable. And I actually saw something recently where there were fMRI images that were, and I'm sorry at the point that I saw this, I didn't take it, but there was the folks in this manuscript postulated that fMRI might be re-identifiable just by the visual image footprint. So things that the rules are moving, the techniques are moving, techniques for re-identification. There's all sorts of re-identified anonymized data sets out there that people have done for research purposes. If you have a unique disease and you're one of 3 people in a given zip code, you can be re-identified pretty readily. And the data that we're capturing is genomic information isn't obvious, but if you imagine the fMRI would at some point be sufficiently unique that you could re-identify that's an interesting thing. So if I can get the slides up that I had for Hanson governance. Yeah, okay, here we are. So I just wanted to put this is a construct that we're working on. Data governance 5 years ago was making sure that the labels on the data was robust as you went from system to system. Now we're thinking about data governance in the way that large institutions that have been called out or found out are thinking about the risks of data sharing with other organizations like Google. And so we have our trustees, and our audit committee is very concerned about the risks associated with, for example, what's happened at Sloan Kettering. Some of you may be aware of the fact that there was some data sharing there. The University of Chicago, there are other groups other organizations that have gotten in trouble with relationships that on the face of it, seem responsible, but where patients have said, hey, I didn't sign up for sharing my data in this data set. So our trustees, our senior IT counsel, we have an Institute for Biomedical Informatics that is very interested in collaborative research. We do a lot with other academic partners. In fact, my own shop has, as we mentioned, relationships with Princeton, not only in this cloud computing, but in other areas. Cancer Center obviously wants to share data. The academic literature and the media, the general media, is now sort of become much more aware of the risks associated with this. There was a JAMA article that came out recently based on the Chicago Medical Center Google partnership, advocating the need for governance to address the potentially conflicting concerns or interests of big data sharing and privacy. We've talked about the moving target of de-identified data, and there's a substantial amount of commercial interest in PEN's data of all types. So we have stood up a data governance, high-level data governance organization to establish principles to guide all efforts at Penn Medicine as to data access, use, and disclosure, to establish sort of our general positions, realizing that you can establish general positions and almost invariably you'll find something that breaches those set of pre-established expectations. So there's always going to be an exception that you need to grapple with. What we'd like to do is get some set of rules in place that cover 80% of the data sharing requests. Identify a proof of concept that represents each of the use cases that we've talked about so that we can run them through the engine and understand how they work. And then convene the data governance organization that, again, very high level in the organization to oversee the process of standing up the governance model and then deal with exceptions as they come up. And so the elements that we've considered in that group have to do with the lawful basis, and this goes back to the stuff that Kristen mentioned, the HIPAA laws, the European legislation that we talked about. We have state laws that in some cases are stricter than those of the federal legislation. The TCPA is the Telephone Consumer Protection Act. So that has to do with the use of cell phone information for engaging with a patient on issues that might be of interest to them. And we also find increasingly we have information on non-PEN patients in our system. So we're sharing information with our local Blue Cross organization. They are sharing their information on claims back with us. So we have information on campus that pertains to non-PEN care, and we have responsibilities associated with that. There are a series of institutional values, including those of treatment, research, education. There are strategic priorities that may have to do with tech transfer, and then there's ethical considerations. When we're looking at a data sharing arrangement, we have to be very thoughtful about the trustworthiness and accountability of the person or people involved with the sharing. So are they employed by Penn Medicine, and therefore do they have employee regulations that are relevant? Are they temps, interns, volunteers? We have people on the campus all the time that have a transient association with the organization, but not a durable one. And once they're outside of our walls, they may, if they retain the data, then we lose control over the data. Contractual affiliations are obvious. Is somebody like a resident who wants to do something with a data set? I had a resident come in the other day and says, I want to create a teaching file of radiology images. Are they closely supervised? He hadn't spoken with his chairman. It was just sort of an idea that he had that would be fun. And, he wanted to develop an app. And we said, well, no, actually, you can't take Penn data off-site for any variety of reasons. We had an interest, this is a sort of a classic situation that would come up for all of us. We had a researcher come to Penn from University of Michigan. That researcher's research assistant or associate was still at Michigan. The researcher wanted to create access for that Michigan-based researcher to access Penn data from Michigan. And we were concerned about that because then somebody's effectively in our system from off-site, and who knows what happens. And is the relationship proposed to be a short-term or long-term relationship? In terms of risk mitigation, we've recently stood up a chief information security officer who is very concerned about the evolving environment around healthcare information. The risk mitigation is we want to make sure that people know about stuff, so it's not sequestered information about who's got access for data sharing. Is it the minimum necessary, which Kristen talked about? We establish the least useful privilege. We don't provide broad access to someone because they're doing research. You minimize the privilege, you minimize the data that they have access to, so we're going to minimize the risk envelope. We try to stay away from using Social Security number, for example. Our employees have special protections and VIPs. We think about VIPs and actually are looking with an artificial intelligence engine at people accessing VIP information. Now, VIP might be Kim Kardashian, but it might also be somebody who was just arrested for a murder. And, those are both inappropriate access. Somebody shows up in the news and you want to look at their information. Our engine is looking at news sources for people that might present as VIPs. Strong security controls we use. We try to minimize access to pen-approved devices or services, which if their devices are encrypted and have the ability to be remotely wiped, and that it's a pen-approved research environment after IS review. And then finally, we feel the need to make sure that we have strong documentation that relates to every one of these data sharing arrangements. So I think that that's probably a good framework to work from for our ongoing discussion. I'll stop there, and yeah, Guy.
So it sounds as if this is all outsiders who want to use or utilize the data within Penn.
No.
Okay, so my question is essentially, what happens when your researchers want to adhere to journal requirements or other requirements to push the data out to GitHub and other?
Yeah. So this is totally intended to cover all internal and external relationships. So if it's, as I said, somebody comes to Penn from Michigan, wants to share information back to Michigan in some way, that is a Penn person from within Penn wanting to ship data out. So, we go through all the same sort of scrutiny, make sure that if it's an IRB approved research relationship, are we using the most constrained, minimum necessary, least level of privilege appropriate for that kind of. So all the same rules are applied to a Penn researcher trying to do their job. And, we don't think of these things as obstacles. It's protecting the organization, but facilitating the research if appropriate. And if we establish, this kind of research has been done before, we understand what's involved in that, then the second time around is quite a bit easier. But pretty much everything nowadays, early on is going to be a new construct.
And if I can follow up, and are there training programs associated with your principles and of access and use for your internal investigators so that they understand all of these things?
I would say that that's sort of a yes and no. I mean, we definitely have HIPAA training and research, training that we've tried to encompass the data sharing aspects of that in those training protocols, courses that they have to take in order to be an approved researcher. You have to go through a research curriculum. I would say that we don't have in-class education on that.
Do you have a question in the mic?
It was brought up during the main session that the cost of the microphone.
Just one thing to note: if anybody wants to pull the microphones closer to you, you just have to yank on the cord. They can move.
Okay.
And the operative word there is yank.
Yank. Okay. I yanked it out far enough.
Good
so
job.
I can speak. So in the main section, it was brought up the actual cost of the egress of data from a data set can be quite large, especially if you're talking about imaging or genomic data. But so having the data stay put not only solves the problem of cost, but also has a security benefit too,
Right.
where you can have your analytics there on the Penn server or in the Penn cloud. You can then, and this could apply for everything, you can then query, okay, a certain polymorphism in a gene that could identify someone, but you're going across the whole database at Penn and seeing if it maybe has a mental health condition associated with it in their EHRs. But the identity is protected, the data is not downloaded, you get to ask certain questions that gives you your answer that you want, but no security is.
Yeah, and this, Kristen, I mentioned this I'm just going to throw this idea out there. This sort of fits under the idea of what I think is something that may be an approach that we adopt going forward, which is a decision support engine that is remote or cloud sourced or whatever, that operates locally on the data, returns a result, but it doesn't mean shipping the data off-site. And this is what a friend of mine, actually who was involved in this research, referred to as knowledge as a service. So we think about infrastructure, software as a service, the idea that a knowledge engine could operate on data without creating all the risks associated with moving data around. The other thing I would point out, interesting, 7 or 8 years ago, we engaged with, and never really, nothing came to fruition with this, but I will share this. There's a company called Blue Talon. Anybody heard of them? Blue Talon provided a construct by which you could use a federated set of data with data access controls. This is a startup that lived from 2012 to 2019, and I saw in the Wikipedia entrance that the company's now referred to in the past tense, and I thought it had gone under. Well, it turns out it was purchased by Microsoft. So it was a way in which to use data from Yale, Penn, Princeton in such a way that there's very strict granular access controls. You don't ship the data off-site, but you were able to operate on the data in situ, to your point.
I guess,
Something's happening.
Just to ask people to hold questions until after Claire has a chance to present, and then we can have a general discussion. So make notes about what you want to ask.
I promise to stay.